Hello, Brian Balke of Hypnosis Rising, here to brief you on therapy for sleep disorders. Our last lecture explored the marvels and subtlety of sleep. Our discussion should also have awakened concern regarding the modern temptations that disrupt sleep. Sufferers will come to you having used other methods to find rest. Melatonin, alcohol, exercise, and nutrition all address one or another factor, but are incomplete solutions. As restful therapists, we address the entire being, and given the complexity here, that demands a strategy for identifying and prioritizing the disruptions. We'll start our lecture with that analysis. While not common, we will delve more deeply into the connection to frustrated stages of development, as these cases can be particularly stubborn. While in our theory of mind, we touch on the importance of sleep for behavioral change, when sleep is disrupted, we need to emphasize strongly the benefits of allowing the subconscious to do its work. We covered this in our technical discussion of mental states, but for our clients, we need less technical language. When the client is awoken by anxious dreams in the middle of the night, the subconscious is struggling to resolve a behavioral challenge. We will briefly cover dream counseling, the general approach that we follow in educating our clients to interpret dreams. This includes practices for dream incubation that clarify confusing imagery. Finally, we summarize the trance strategy with general suggestions appropriate for minor sleep challenges. Some of these will be beneficial with other therapies, as they encourage the subconscious to prioritize therapeutic goals over existing concerns. In sleep therapy, however, the suggestions are narrowed to achieve more effective sleep. In our survey of applications, we identified sleep as a universal concern. This is partly why we start our lessons on therapy with sleep. In developing your understanding of therapeutic practice, sleep also has another benefit. It is relatively straightforward. In a few slides, we can define an investigative approach that feeds directly into trance work. The overall structure follows our therapeutic strategy. Our subconscious mind rules the realm of sleep. Obviously, then, lack of sleep occurs when the waking conscious mind is too active. The symptoms of sleep disorders diagnose that imbalance. Is the conscious mind too assertive, or does the subconscious feel impotent? In either case, before granting rest to the conscious mind, the subconscious seeks the safety of routine. Lack of such routine is the concern of sleep hygiene. We search out factors that impede or disorganize the surrender to sleep and recommend alternatives. Having established rapport with the client's condition, alpha state elicitation, we engaged a delta state problem-solving process. Our psychoeducation explains the learning partnership and why sleep is so important to personal growth. In this presentation, we will focus on the lessons that apply to simple sleep disorders. Given the importance of dreams, we will enrich this dialogue in future modules, including trauma and developmental crises. Dreams are the vehicle used by the subconscious to raise concerns, often from pre-verbal networks. Dreams therefore reveal images and associations that defy logic. Dream interpretation works to clarify the dialogue. We then walk step by step through the trance work. This will be incomplete as we have yet to cover all the techniques. We will address that in the lectures to follow. For now, we emphasize the goals of each step. Now let's elaborate the pre-trance or cognitive portion of this session. Our investigation begins with basic symptoms. At this point, we are looking for critical factors, so suspend analysis and education until the survey is complete. Upon retiring, how long before sleep follows? What mood and thoughts consume those hours? Is physical discomfort a factor? Temperature and posture may factor into discomfort, but also muscle and joint conditions that may require medical diagnosis. Or does the client wake in the middle of the night? On occasion, this occurs to all of us, but when accompanied by anxiety or worry, it can disrupt sleep. How long is a typical night's rest? How often do they wake feeling ready for the day ahead? Do they remember their dreams? Most typically dreams in the middle of the night, or just before waking. What themes predominate? Do they have night terrors, or dreams accompanied by panic? How consistent is their bedtime routine? If it involves screen time, the release of melatonin is delayed. Do they disconnect from the concerns that dominate their day? Recognize that for a busy professional, any automatic behavior, such as folding laundry, may qualify. How about the last 15 minutes? Do they dress, wash, and brush in the same sequence? In the 6 hours before sleep, do they use stimulants or relaxants? Do they take prescribed medications? Do they self-medicate, whether using over-the-counter or illicit drugs? When do they eat their meals? How long before bedtime do they have their last meal? How long between that meal and the first meal of the day? We may note at this point any correlations between night terrors and hunger in the middle of the night. Poor nutrition also reduces our ability to control cravings for substances, whether sweets or mind-altering substances such as alcohol and tobacco. When anxious thoughts are a challenge to sleep, we survey the sources of distress. Do they experience physical discomfort? Is stress waiting for them in bed in the person of their intimate partner? Or is it rather lack of a partner? Are they able to put work away when lying down, or are they haunted by unresolved problems? In each area, what emotions are felt? Where are they carried in the body? What attitudes would bring relief? Sleep disorders are often tolerated early in life. In some, 4 hours of sleep is considered a competitive advantage, until the body and mind begin to rebel. We thus ask whether sleep challenges can be recognized in earlier years. Insomnia is one method of delaying changes in the brain architecture to match social changes, which we know occurs in establishing a social identity, which may be the driver of ADHD. The pictures here evoke the dethroning of parental authority in adolescence, development of moral maturity in adulthood, and shedding of material for spiritual concerns upon retirement. When sleep disorders are recognized in earlier years, we should ensure that any social crisis may be surfaced comfortably. If not, we need to caution that progress may require deeper work, perhaps including referral to a clinician. We can still proceed symptomatically as described in the trance work, which is organized around memories of a safe, solitary interest or experience from that age. Finally, we always want to encourage the subconscious with positive expectations. How will better sleep positively impact the client's life? Common expectations include improved attitudes, alertness, physical well-being, and relationships. We may need to prompt the client to expect improved control over impulsive acts and habits. Having identified the client's concerns and goals, we then turn to problem solving. Our orientation holds that sleep disorders reflect a breakdown in the collaboration between the conscious and subconscious minds. We will facilitate behavioral change through subconscious motivation, but the conscious mind needs to recognize and validate productive change. Our psychoeducation prepares the client to offer that reward to the subconscious. In doing so, they learn a pattern that will change their relationship with themselves, ultimately improving all aspects of their life. We start by summarizing the sleep process for the client. Sleep is a surrender of control to the subconscious mind. As the subconscious seeks routine, the best way to encourage it to come forward is to simplify our bedtime routine. So their first responsibility is to establish a bedtime routine. To ensure its effectiveness, they should also avoid the disruptions listed on our sleep hygiene one sheet. These are adapted from recommendations from the CDC. There are two distinct phases of sleep. Non-REM sleep, or NREM sleep, which is dreamless, is important for long-term memory storage and physical healing and strength. This extends to the brain itself. NREM brain waves are highly organized. Alcohol and caffeine disrupt that coherence, preventing NREM sleep. Even if we get a full night's rest, if NREM is prevented, we will still wake feeling groggy and depend on coffee to get through the day, which makes the problem worse, of course. Dreams occur during REM sleep. Often dreams were considered random noise, but in fact they are how the subconscious changes behavior. The body is disabled and often in a safe place. The subconscious taps into the imagination, replaying past events and inventing new scenarios, seeking ways to overcome obstacles and grasp opportunities. When woken by dreams in the middle of the night, the subconscious has hit a roadblock. It needs guidance, and if we can stay calm and offer reassurance that we will seek resources and supportive relationships when awake, it will allow us to return to sleep. Conversely, when the subconscious discovers that it can address the current goal by giving up an old one, it will seek confirmation with a venting dream just before waking. If we are upset by the dream, it may conclude that it needs to hold on to the concern and continue working on the problem each night. Nightmares are not a normal dream material. While we think that we aren't burning much energy while asleep, the body is actually doing a fair amount of work. If the gut doesn't have something to sustain the work, we can have a blood sugar deficit in the middle of the night. The brain, which can only last a short time without sugar, will trigger a panic attack. Naturally, the associated dreams are full of death imagery. Sorting through our life experience and inventing new behaviors is complicated, and so the mind checkpoints progress by returning to NREM sleep. A normal night's rest has 5 NREM-REM cycles. In relating the theory of mind, we must include the learning process. You have dialogue in the TOM view graphs, but these important points can be repeated should the client continue to use anxiety to enslave the body to the ambitions of the waking mind. Healthy collaboration between conscious and subconscious is the foundation of self-trust. While our waking relationships are essential to our well-being, we have to listen to our bodies to know whether that well-being is real. Conversely, as adults, the subconscious may not fully appreciate how important our virtues are to social success. We need to identify and communicate those traits so that it can plan for their use. While we can invent a solution in waking life, the subconscious uses dreams to convert that solution as a behavior that can be repeated. Not only will it fine-tune the networks in the brain, but plan diet, grow muscles, and balance priorities. In doing so, it uses 9 times as much mental power as is available to us in waking life. To help prioritize the work in dreams, we can use the trance state to incubate dreams. This can be done in session or by journaling in the natural trance state that occurs in the 15 to 30 minutes before bedtime. In many cultures, dreams are considered to be messages from the subconscious. Remembering that the subconscious is a portal to the body, that includes guidance from ancestors, deities, and other archetypes. Carl Jung, acolyte and rejecter of Sigmund Freud, championed the idea that certain archetypes are universals. The new student of dreams may thus be drawn to books that claim to decode dream symbols. Paradoxically, Jung held that all psychotherapy must recognize that each sufferer has a unique language of experience. In Jungian psychology, the therapist is responsible for clarifying the meaning of those terms, thus opening the door to new choices. In Christotherapy, the client is responsible for this work. Our methods therefore seek to facilitate the client's journey into deeper understanding. The basics of dream study are universal. The dream should be recorded immediately upon waking, for if delay is allowed, the conscious mind will layer on expectations. The puppy in the dream that was resurrected from the beach in childhood will associate instead to the puppy in the poster at the coffee shop. Given that the dream is captured in its raw form, we proceed as follows. How old are you in the dream? This serves not only to diagnose the maturity of the issues exposed, but also pushes the client gently out of their contemporary perspective. We continue by sorting the elements of the dream as concrete or abstract. The concrete elements may associate with events and emotions, but often the abstract elements disturb the pattern. How to understand this? Well, if the client struggles with role confusion, the first occasion of that confusion may have been well before adolescence. It may have been in a second grade school play, upon grasping that the cute hobby horse they rode was inconsistent with the gravity of the hero's struggle. That hobby horse may appear as a noble stallion in the dream. How to penetrate these layers of association? First, we need to get out of the narrative mind, descending into the realms of emotional and physical memory. We can then trace the element of the past. Where did it come from? And into the future. Where is it going? The first question associates to the networks of expectation that limit choices. The second activates our deepest hopes for resolution. Recognize that as an external witness, we may grasp the truth before the client, wrapped in their webs of expectation and habit. For the purposes of therapy, we need to facilitate that struggle. This is known in pedagogy as Socratic synthesis. We question rather than interpret. How does that align with the emotions you felt? If the block is dense, we may lead gently. Could it be that the puppy was first seen in childhood? An abrupt rejection may itself be indicative. If progress is stifled, we help the client craft a script to elicit further insight. Each night before laying down to rest, they handwrite the request. I would like to know more about the puppy that appeared in my dream about my supervisor. Given the foundation of sleep therapy, we can now proceed to diagnosis of symptoms. Most of the major disruptions originate from behavioral paralysis. We extend the distractions of waking life as long as possible, rather than working to invite the subconscious to assume control. We cater to the cravings of the brain for sugar and flavor, rather than following the counsel of our gut. And we use anxiety to summon energy from our metabolic reserves, rather than working to change our relationship patterns. Learning is always the answer to these problems. We emphasize that daily life is full of deception and manipulation, and so we develop new behaviors and dreams when the entirety of our lived experience can be weighed. The subconscious is not against us, but actually our oldest, dearest friend. In trance, we will work to restore the trust necessary to that collaboration by ensuring the subconscious that the waking mind is eager to strengthen the body to the degree that it is willing to cede authority to the subconscious to seek solutions to social problems in dreams. With the investigative work completed and the priorities established, we turn now to the trance work. In the trance work, we weave the information gathered in our investigation of the client's difficulties. In this outline, we tag the relevant slides from that section of this presentation. While we commonly use the arm raising or peace inductions in the first session, a progressive relaxation should follow to remind the client how to surrender physical tension. In follow-on sessions, the progressive is used for induction, with variations that address specific areas of collaboration between the two mental realms. For simple sleep therapy, the script provided for trance induction should be sufficient. For the remainder of the trance work, we will outline suggestions specific to sleep therapy. The progressive is followed by two deepeners that will be elaborated in our next lectures. A rigidity challenge is used to release social stress, and a descent deepener to introduce the desired moral identity to the subconscious. Both techniques build collaborative trust that facilitates falling asleep. Following the descent deepener, gentle self-parenting may follow should a developmental crisis exist. The remainder of the trance work addresses the sleep process. We give the subconscious permission to initiate and manage the sleep process. If the client is woken by stressful images and dreams, we desensitize those reactions using techniques that will be addressed in our discussion of panic therapy. Finally, we incubate dreams, seeking to shift focus from past concerns to future opportunities. We start, of course, with the softening of internal blocks. The progressive relaxation is one of our most potent therapeutic techniques. The formula offered in our lecture on trance elicitation prioritizes somatic reconnection, which can be the first priority in sleep therapy. From session to session, however, as the onion peels, we may emphasize other aspects of vertical balance. A descending progressive from head to toes can strengthen the authority of the mature identity. Radiation from the heart can highlight the interdependence between physical well-being and social success. We will elaborate upon these lectures in a lecture to come. We will elaborate upon these variations in a lecture to come. In that study, you will practice weaving of beneficial attitudes into the progression. When sleep disruptions are tied to anxiety and worry, that theme should be the client's identified emotional antidote to the anxiety or worry, which may be calm or trust. Every version of the progressive, upon arriving at the center of the forehead, turns to plans and priorities. In the upward progressive, this is a fertile opportunity to activate behavioral consolidation in NREM, delta state sleep. We insert there with the physical being adapting to support those plans and priorities, and the plans and priorities adapting to the capacities of the physical being. Remember that at this phase of the trance work, we speak in generalities. The goal is not to change behaviors, but to encourage receptivity to change. With the rigidity challenge, we turn from gentle encouragement to a fairly aggressive liberation from negative conditioning. From our theory of body syndromes, we know that when direct reaction to social stress is repressed, the mind will turn anxiety inward as muscular tension. Breaking that connection allows the conscious mind to assume its appropriate role in resolving social problems. The focus is on the emotion or attitude that arises when struggling to find rest. The dialogue of the rigidity challenge moves that burden into a part of the body, such as a fist, that tightens, squeezing the psychological energy so that it cannot escape. A countdown from 5 to 0 intensifies the tension. Until at 0, the client is told that they will fail if they try to release the tension. With a final deep breath that purges the body of any remnants of negative apprehension, the client releases the energy and relaxes their muscles, allowing them to enter an even deeper trance. Having liberated the body from responsibility for social distress, we then work to introduce the subconscious to the resources of the mature social identity. This disrupts the networks established in childhood that rely upon others for moral guidance. A descent deepener uses the metaphor of downward motion. This may be a staircase, escalator, or path. The client visualizes themselves manifesting in posture and expression the virtues that will empower resolution of their social stress. The imagery adopts the subconscious perspective, looking upward at this image, which then descends in 20 steps, turning the virtues inwards in service to the self. As the bottom is reached, the virtues infuse the physical being and the client is guided into a deeper trance. The process concludes as we encourage the subconscious to turn its efforts to expression of the self that is most desired, true within, and thus inevitably real when expressed without. If the client is harboring wounds from an unresolved developmental crisis, we then bring the mature self to aid of the younger self. From the place of descent, the client navigates toward a younger self. We transform the environmental imagery until reaching a door to the secure environment, an experience identified in our investigation of developmental crisis. Upon entry, the client reconnects to the joys of absorption in the cherished activity. The younger self is given authority to initiate the interaction with. When they acknowledge you, you step forward to converse. The generalized sharing what is most important is then elaborated with specifics. Strong, pretty, talented, smart, or whatever affirmations the client revealed were missing from others in the crisis. The encounter concludes with an agreement to continue to work together in dreams to allow the qualities lost in childhood to flourish again in mature life. Turning now directly to sleep, we educate the subconscious regarding the structure of the process. The suggestions adopt the subconscious orientation toward the body, thereby prioritizing organic well-being. During the routine prior to rest, the subconscious will prepare the body for sleep. When placed in a posture to sleep, you will fall asleep quickly and easily. As you enjoy deep restorative sleep, the body and mind will recover and strengthen. With that foundation, we turn the focus of dreams towards social well-being, shifting focus from unresolved crises towards waking success. The cycles of dreaming are used to pace the return to wakefulness. Finally, the compact is reciprocated, with a commitment that the waking mind will adjust its priorities to support these outcomes. When the client is beset by recurrent, frightening dreams, we can use desensitization to establish the authority of the mature self to achieve a resolution. Such dreams normally occur when the subconscious holds on to a trauma, seeking a way to avoid recurrence, even though the possibility is remote. Psychologists have learned, for example, that after an urban fire, residents in unburned homes are more likely to have frightening dreams of their home burning. They offer the explanation that those that lost their home are relocated, while those unaffected face constant reminders of the devastating effects. While the repetition of the fire is low, the severity of the consequences overwhelms the subconscious, which spends each night trying to find a way to prevent a similar loss. Desensitization is a powerful procedure. We will devote several sessions to its mastery. Here we outline the basics. In trance, we establish an ideomotor signal, telling the client that they should raise their index finger when they feel the emotions associated with the dream. The descent deepener has already brought the moral self as an ally. We then invoke the image, waiting for the ideomotor signal. After a time, we ask the client to take a deep breath and dismiss the image, restoring the calm that is desired. As the image dissolves, we may assert through the moral self that the image is no longer present within, allowing dreams to return to creating alliances that will prevent its return. In the last of our compacts, we celebrate the collaboration between waking and dream experiences. First are the benefits that will accrue from deeper rest. Allow yourself to visualize the future, sleeping well every night, in which you enjoy, followed by the benefits identified by the client during investigation. In the intimacy of trance, the client is then encouraged to witness the commitment of the subconscious mind to their success. The conscious mind then offering a reciprocal gratitude. Knowing that the subconscious is committed in dreaming to full support of your goals, each night the waking mind will surrender gratefully to sleep. We then encourage the subconscious to surrender outdated concerns, so that in the middle dream episode, it can turn its full attention to plans for achieving your goals. Finally, we suggest that those outdated concerns will be passed forward and vented in the dreams just before waking. Any expectations and beliefs that only inhibit the realization of your goals will be passed forward and released in the venting dreams before waking. Remember, of course, that the compacts we have laid out are reinforced before counting the client out of trance. So there you have it, our first fully developed therapeutic program. Recall that we started here for two reasons. Sleep, where behaviors are crafted and consolidated, is essential to personal growth. And sleep therapy is relatively simple, allowing us to trace the application of our histotherapeutic strategy from investigation to softening of inner blocks before establishing new compacts. Your complaint may be that the trance work is not fully scripted. With your appetite whetted, it's time to begin detailing our techniques, beginning in the next lecture with the rigidity challenge.